conversation is different. We've already started conversing on endometriosis, and we're taking it another level because we already have our guest here in the studio. He is Dr. Victor Ayodeji Omolono. Is a board-certified obstetrician and gynecologist with over 13 years of clinical experience and research. He's a fellow of the Medical College of Obstetrician and Gynecologists, a member of the West African College of Surgeons. He has certificates in public health from Harvard University and Johns Hopkins University, likewise a diploma certificate in international health systems management from the University of Liverpool. He is a director of the Restoration of the Dignity of Womanhood, a non-governmental organization promoting women, girl, child health and rights. He's a voiced advocate of women and children locally and internationally. He currently works as a consultant gynecologist, reproductive endocrinologist and fertility specialist with Bridge Clinic, Lagos. Please welcome Dr. Victor Ayodeji. Good morning.
Good morning. Glad to be here again.
It's so amazing to have you again. Thank you so much for joining us.
Thank you for having me.
Yes, we have opened up a conversation on endometriosis, but to give it more context, I'd like to ask, what exactly is endometriosis?
All right. Endometriosis is a clinical condition in which endometrial glands and stroma find itself outside the uterine cavity. I don't know, breaking that down, the uterus is the womb, as the layman knows, and it has like 3 layers: the outer covering, the middle layer, and the inner layer. So that inner layer is the uterine cavity. So cells there that are usually shed during menses, once they find themselves out of that place to other parts of the body, you know, it's termed endometriosis. So you can find itself commonly around the ovaries, you know, in the tubes, in the peritoneal cavity, that's the abdomen. And due to other mechanisms, it can actually find itself in distant organs such as the lungs and even the brain.
Oh, wow. Yeah. Interesting. Now, you know, what is popular, the moment you hear endometriosis, what people know is a painful period. Yeah. So that would lead me to ask you, what exactly are the symptoms of endometriosis? Yeah,
endometriosis has a myriad of symptoms.
Okay.
And the reason why it's not easily picked up is because its symptoms, you know, mimic a lot of other symptoms of other diseases. Okay. However, cardinal amongst it is that pelvic pain, which is a chronic pelvic pain, you know, and it's found that this woman, because this, okay, let me even talk about let's say that the pathophysiology or how it comes about. It's said to be that following, we call it something called retrograde menstruation. So people that possibly have, they started their menses early in life, people that have a kind of heavy flow, you know, people that have also shorter cycles, that is, they see their menstrues quite often, you know, than others, they have a risk, you know, of having this endometriosis more, you know. So when the cells find itself outside that cavity where the baby actually stays, which is the inner lining of the womb called the endometrium, you know, what happens also during menstruation, you know, happens also in all those other places. That is, when they are shedding, like probably when they're having all these normal signs of ovulation, all those other sides will be having those similar symptoms. So when the menses also is shedding, those other places will be shedding. That's why you see that some men probably they have this endometriosis maybe around their surgical site, because sometimes when you do some surgeries, those cells also can be transplanted. That is, they can get moved, you know, probably during mammectomy, during fibroid surgeries, during cesarean sections. Those cells in the inner line of the womb can find themselves on all those sorts of surfaces. So when they menstruate, you see that they'll just be seen bleeding around their surgical site, you know, and things like that. So that's why they feel the same pain they feel, you know, when they are menstruating. So pain is a cardinal sign of endometriosis. Okay. And that's why it's good to actually investigate further, especially it's found in women of reproductive age group, so women that are menstruating. Those are people you can find endometriosis in, you know. However, some can persist beyond the menopause. Okay. However, it's major around the reproductive age group. So women that are, even girls, find out that girls that have possibly initially you were not having painful menses, but suddenly in life just start developing, realizing that you're having painful menses, it could actually be endometriosis. You know, and also aside that, it's said that it affects about 2 to 10% of the female population, which means that about 1 out of 10 women actually can have endometriosis.
Yes.
You know, then also it's another, besides pain, infertility is actually another major symptom or occurrence in people that have endometriosis.
Now, with all that you have stated, it makes me wonder, what are the risk factors?
Okay.
Like, what are they?
Okay. So the risk factors for endometriosis, I mentioned some of them. Genetics play a role.
Okay.
You know, so found out that people that have first-degree relatives, possibly that their sisters, you know, have it, they also can have it. You know, also in the daughters who can have it. So aside that, I've said people that started their menses early, you know, in these days, you know, before people start menses probably around 13, 14, but now because of, you know, increase in nutrition and, you know, and development and all, girls start as early as 9, thereabouts. So the early they start, the higher they, because that means they are exposed to, you know, what actually causes this endometriosis more, you know. Then also there are people that have shorter cycles, that is possibly they see their menses less than 24 days in a month, so they're probably seeing it every 22 days. So that increases the chance of all those cells migrating, moving from that endometrial cavity elsewhere. Then also, you know, probably having surgeries, not meticulously doing all the surgeries like fibroid surgeries, like cesarean section, and not, you know, meticulously doing all that. You can actually transplant those cells in the endometrium outside, you know, that part. So that also are just the common risk factors that are responsible for endometriosis.
So we got some stories that I'll be sharing with you. There was one that we'd already taken before, but I want to share it now because I would like you to shed more light into what this person actually went through. Okay. And I realized that some of the stories have similarities, but also differences. There's the first story that we shared from Zena Balogun. She talked about the fact that she had been going through pain, but she did not know until later on in life that this was what was happening to her. And she, at some point during treatment, she was losing her hair. She after about a year, and then she likened the pain to someone taking a barbed wire to your insides and twisting it continuously for days on end. So how does that come into play? Because now she's talking about the kind of experience and pain, and she said painkillers did not work at all.
Yeah. Okay. All right. Let me just start, because endometriosis is a broad topic. But of course, it's good to just use this kind of medium to educate people. Okay. So the pain of endometriosis could be mild, it could be moderate, it could be severe. Okay. You know? So
also there are types.
There are types, so there are grades. So it could be mild, moderate, severe. So I think he has, you know, the worst form of endometriosis, and it's not even in possibly it's mild, but with the ones that have what we call infiltrate, that has entered, you know, more into the organs, like the surface of the peritoneum. Those ones cause more pain. So I think that's actually what she experienced. So apart from that, you know, aside the painful menstruation that they have, they also have these they can have pain during urination, because these things also can find themselves around the bladder, can find themselves around the ureters, where they can encase it like this, like, you know, they can find themselves even around the bowel. So possibly that she has all those types, you know, can even cause obstruction, that they will just be vomiting, they won't go to the toilet, they can have painful defecation, that is when they go to the toilet to poop, they can have pain, you know. Some even can have blood in their lungs. You know, I've not talked about, so it's a myriad of, you know, pathogenesis. I talked about, you know, they can even, because those cells can actually go through the lymphatics or through the blood and move towards the lungs, you know, area. And some even have it in the brain and have seizures, you know, so having convulsions and things like that. Yes, so you can actually find, so when you have all those kind of endometrial-like tissues in the brain, once they start menstruating, they start shedding also in the brain, they start bleeding also in the brain, and you can have seizures like that. Okay,
I would like us to take it back a little bit. You said something about the types, and I want us to take it step by step, so that we can actually understand, because now you have, you know, opened up so many things that can actually happen to people, and a lot of people are out there going through these things and they don't even know that this is what is the cause. And another thing that I picked up from some of the stories which I'll be sharing as the conversation goes on is, they were not diagnosed right for so many years until one of the ladies in the story said she had to go for an ultrasound when she was trying to get pregnant, was when she realized that this was what was happening and this was why she was going through so much pain. So let's go back to the types of endometriosis. What are they and what levels? And, you know, what takes you from one level to another?
Okay. The types, as I say, just graded. You know, because the classification differ depending on when you want to use the body anatomy, you want to use the severity of the symptoms you have.
Yeah.
So if you want to use the severity of the symptoms you have, you can say it is mild. You know, people can just have just ordinary, just mild pain during menses. You know, this low pain that is not just there. You know, moderate when it's now a little more intense, you know, than just the mild. You realize, okay, it's affecting your normal daily activities. And, you know, endometriosis is something that affects the quality of life. That it's beyond just the menses. It can affect even their work functioning, psychology, even mental health. Because as you talked about Zainab Balog, I'm sure, you know, something that possibly affected her functioning even in a normal other spheres of life. So severe now is when those cells now, they are now like finding themselves outside, moving outside of their cavity. It affects commonly, I said, the ovaries. So that can call the ovarian endometrioma. So when those cells, you know, start coming together, you know, they can now form like a bag, like a cyst. You know, so when the menses come, it keeps shedding. You know, when a lady sheds a normal menstruation, it comes out. You know, after, assuming when it's tailing off, it becomes brown. So because those cells and those shedding don't have a way of escape, they will just keep shedding inside that like cyst, that bag. So over time, they now keep expanding, keep expanding. You know, so if it's not detected in time, that's when. So anytime the lady is now menstruating, she'll be menstruating inside that bag, and now be causing her so much pain, you know. So that's like bleeding. They call it like an hemorrhagic cyst, so like an endometriotic cyst. So have this chocolatey kind of structure. Then also you can find herself on surface of the bowel, you know, side of the intestines. So just be there. So anytime she's menstruating, those places also will just be bleeding, you know, but she will not know. And once there's bleeding inside that, they will be irritating, you know. And because these cells also release what we call the prostaglandins, you know, so they are painful. They're like all these painful chemicals in the body, and they just be, you know, bleeding on top of the abdomen, and you don't know, and just be causing out so much pain. So until that menses stops and the body absorbs maybe all those bleeding, that's when the pain can just go down a little. So when the menses comes again, the cycle starts again, you know. So
I just want to ask a very quick question so you can continue.
Okay.
The pain only comes when menstruation starts? Is that when the pain features? You
know, it's there. So it's going to be like a continuous pain, but it's going to dull off during when she's not menstruating. Okay. But when the menstruation starts, it can now get worse. Oh. Especially when it's already formed like kind of cyst, because it's now getting bigger and bigger with each cycle. So when it started initially, it could be small. With another menses, it gets bigger. So it could take a lot of maybe like 5 years before it now becomes something so serious that it's now becoming an excruciating pain. And if she's kind of unlucky, that kind of cyst can even now tear open and rupture and now spread all over the abdomen. So that kind of case will now be when she will know and now rush like for an emergency. Oh, do you not realize when they now open up, they don't realize that, oh, it's actually an endometrioma. Wow. And the diagnosis, you know, because it mimics a lot of things. Commonly, we just say, okay, it's just menstrual pain, give her painkillers, you know. After a period of time, that will not suffice. You know, that's why we talk about hormonal treatment for endometriosis. You know, so we talk about hormonal treatment for them, from the combined oral contraceptive pills to the progestogens, to the other what called gonadotropin agonist. So depending on the level, you know, so we just, you know, because the manual of endometriosis also is a case by case basis. I cannot use what I use in managing A when you're, so I have to look at your history and clinical history and really share the same approach, because the thing is, not everybody also is able to afford some of the things that are, you know, needed to manage it, because there's also medical management and surgical management.
Oh, all right. Yeah. I'm going to take this story and then we can continue with the conversation. All right, so Charlene, a novelist in Newfoundland, Canada, also shared her experience. She said her period was very painful, for she had seen other girls handle it and joke about their cramps. In her words, for me, it was nothing that I ever wanted to joke about. Looking back, Charlene thinks her symptoms started when she was about 11 years old, but she was officially diagnosed with endometriosis when she was 27, and so for 16 years she talked to a lot of doctors. This is just what it is to be a woman, says Charlene. She said that she was advised to use some painkillers, but nothing worked. I thought I must be really weak. I felt like there was something wrong with my ability to be a woman. She further shared that her pain got worse in her 20s, especially during sex. My fiancé at that time, well, our intimate times were becoming very painful, says Charlene, and that didn't seem normal. So I started pressing doctors for answers again. But again, they dismissed my complaints until I tried to get pregnant. Once she started doing fertility tests, an ultrasound revealed she had endometriosis, and that was in 2014, when she was 27. Charlene scheduled surgery right away, but because her endo was in her ovaries, which she needed in order to get pregnant, all the doctors could do was drain her cysts. Finally, having surgery should have felt like a victory, but it did nothing to relieve her in pain or her fertility struggles. She mentioned that she has good days and even sometimes good weeks, but there are the weeks when the endo is constant. To manage the pain, she has changed her diet instead of taking painkillers. She said that she has completely ruled out dairy, gluten, sugar, alcohol, and processed foods from her food. She shared that her biggest fear is what will happen in the future. I've always wanted to be a mother, and since that might not happen, I have this emotional up and downs trying to figure out where my life will take me, if being a mother isn't part of my future. Now, this is a very deep story that showed that she actually went to get checked. Severally, she was dismissed severally because you already mentioned it, that endometriosis mimics other types of illnesses and stuff. And what really gets me in the story, which I'd like for you to, elaborate on, is the fact that she actually went to do a surgery. I'm guessing you already said there's a medical part and then there's a surgical part. So she took the surgical part. But it still didn't stop the fact that she has pain. Can you explain that?
Okay. It's unfortunate for our case. However, as I earlier mentioned, and she mentioned another symptom. Between the symptoms are myriad, and there are symptoms that are not like specific. They are non-specific. So you cannot say, oh, this pain is from endometriosis. She talked about dyspareunia. Dyspareunia is when you have pain, when you're having sex, and the kind of pain associated with endometriosis, because those cells, those stroma and glands of the uterine cavity, they can find themselves also in the vagina, in the posterior fornix, that's at the back of the vagina, So when you go into the deep dyspareunia, there's ladies that will call it superficial dyspareunia. That is initially due to maybe lack of foreplay or poor lubrication. A lady can have superficial pain during sex, but once the lubrication is there, she should not have pain. But when the pain is now persistent, then you should start, and she has that history, the doctor should start having what we call the eyedness or suspicion, like, oh, this could actually be endometriosis. So as I said, so maybe I should just rule out the symptoms, so that if people that have it can just, so like painful, chronic pelvic pain that just have pain almost all through, which could get worse with menses. You can have what we call this deep penetration sex, so they're already like probably married. They can have pain during urination if it's already around the body. They can have all this tummy pain. They can have pain during defecating, because normally painful, and when they are defecating, it could be bloody, especially during that particular period of time. It's really like a cyclical thing. That is, the bleeding comes almost around the time they are menstruating, because that's when those cells will shed. Because they are like cells that are supposed to be in the womb that is elsewhere. So when they're menstruating, they can be having painful defecation. They can have painful urination. They can have cough out blood. So those are the things that are in them. However, for this case, as I told you, they're medical and surgical. Once it is established that it is endometriosis, and how do we establish it? One, clinical history. So the doctor must put at the back of it. So put at the back of his mind that, oh, this could actually also be endometriosis. So you have to investigate further, and it has been advocated that you should use what we call ultrasound scan, as you said, and also you can use an MRI. that's the magnetic resonance imaging, to actually diagnose endometriosis. Back in the days, we believed that, that the diagnostic laparoscopy, that is the minimal invasive surgery, that's the penile surgery, you can use actually to look into the abdomen. You now see all those, like petechiae, like chocolate teeth on the surface of the peritoneum. That can actually diagnose it. But the European Society of Women Reproduction and Embryology have said that, if it is not, that's not the first line now, just ultrasound scan actually can give it away, especially if you're already having cysts in that in the ovary side, because that's the commonest place it first gets to before, because if you look at the anatomy, the womb is just like a pear-shaped organ having tubes that links with the ovary. So once the endometrial cell flows, it flows towards that ovaries and encases and also gives the kind of, so once you keep shedding, as I said, over time, it starts getting bigger. So for the case of Charlene, if I get the name right, rather than, it advocated that the European Society of Women Reproduction and Embryology also said that rather than drain the cyst, because if you drain it, it's going to get filled up again.
Okay.
Do you understand? So that could be why that pain did not actually regress significantly. So rather than do that, you can actually remove, do what we call a cystectomy to remove that bag. So if you just, probably put a pin or drain it out, it will, when you start shedding, menstruating again, it will fill up. So you remove that cyst, and you can actually, call it like a debulking. You can actually remove it significantly. And because it's associated with 50% of, because it's in the women of reproductive age group, that is women that are looking forward to get pregnant. It's because now she's saying that she cannot get pregnant, but there are other ways in which women with endometriosis can actually get pregnant. So, and that's what we need to also shed light on. It's not like a bus stop that when you get to once you're endometriosis and it's kind of affecting you, your ovaries and all, you cannot get pregnant. Of course, it reduces the chance of natural conception. Significantly, because of what we call it causes all these pelvic adhesions. Adhesions means like gumming together. It makes those cells to be stiff. So normally the tubes are flimsy, they just swimming and all. So during the ovulation, once the ovary releases egg, the fimbriae of the tube will go and catch the egg and move it towards the ampulla, when the sperm meets it and they fertilize and things like that. But in this case, the endometrial glands makes those the tubes and they get them fixed and distorts the anatomical position. So rather than being like a fimbriae like this, they can get stuck at the back. So the ovary just releasing the egg just into the peritoneum. The fimbriae cannot swim freely to go and pick it up, so they are just stuck. So in that way, natural conception most likely will not be possible for them. So first of all, if the cyst is significantly large, it can get removed. Though we've also been said that because surgeries also can damage the ovaries, if they want to get pregnant, they can have what we call the ovulation induction. They can stimulate them with some hormones, and ultimately they can have what we call in vitro fertilization. That will boycott all the use of using the tubes. All you need to do is just to stimulate these ladies with hormones. Get their eggs retrieved, fertilize the other sperm, and now implant it into the womb. So we boycott. You already boycott using the natural conception of the ovaries.
Some form of fast tracking
it. So IVF is actually advocated for women with endometriosis. So women that have it should actually seek help, in centers that can afford to do such. First of all, you can try ovulation induction. If it doesn't work, you can step up to IVF, and it helps them a great deal. And a lot of success stories have come up with that from that.
I mean, because when we first started the story, the conversations this morning, a lot of fears were popping in my mind. Okay, so does this mean that, at this point that we're at in terms of science and everything, women don't have solutions? But now that you're talking about it and talking about other, because a lot of women out there, I've seen, apart from the stories that we're going to share this morning, I've seen other stories where people are really struggling, especially when it has to do with giving birth and having children. But with this that you have mentioned, it's a bit relaxing that as long as you can go to places where you can afford it, or centers where you can also get good doctors that can advise you, these things can work. I'm going to share the next story. This is from Lisa. Lisa says, and this is another woman that has shared her worst experience, was when she realized that she had literally been bleeding on and off for 21 days. That was after she had been on the pill and doing things in order to stabilize her cycle. Then she went to her doctor, who referred her to a gynecologist. The gynecologist said there are a couple of options for her. The first option he presented to her was what her mother had done, which was a radical hysterectomy. Hysterectomy, yes. I was 17 and I just remember sitting there thinking, is this person crazy? She said she left and saw a different gynecologist, and that gynecologist mentioned that she had to do a laparoscopy to know what it is. After that, he diagnosed her of chronic endometriosis. I guess I felt positive because he had a diagnosis. It's nice to be able to name what you've got. Then you can start talking about it. It is no longer the elephant in the room. This also means that there's potentially a treatment for it moving forward. And also visually, we had pictures. I could see the scar tissue already at 18. My ovaries were covered in endometriosis. I was a young girl who had big dreams. She shared that the condition was controlling her life. It was affecting her sex life, even her professional life, because she didn't want to go to work and be unable to do anything. It was a struggle for her. She then decided to do a lot of exercise, proper diet, and naturopathy. She did more of home-cooked meals, took very little processed foods, and yoga meditation. She said, that was a big turning point for me. It was an opportunity to take the reins and tell a different story. The pain is real, the conditions are real. It's not necessarily going to go away, but it's not going to ruin me. I'm not going to let it impact me, and then I'm going to be powerful, the powerful one in this situation. And that's how she's been able to live her life. So, and at the end of the story, she talked about having a child and all of that. She was able to get through and everything. So let's go back to what she was able to do. I mean, she was advised to take a
womb out?
Yeah. That's the hysterectomy.
Hysterectomy, that's removal of the womb.
Hysterectomy. Please, can you say it again?
Hysterectomy.
Hysterectomy. Yeah. All right. The hysterectomy. That's for her to take out a womb.
Yeah.
Wow. Why? Can you explain that to me? Because that's scary. She was 17 at that point. For somebody to have told her to do that, that would have been very scary.
Yeah, well, it's the knowledge of a person that's, So then you need to seek advanced knowledge. And, the world is a global place now. You can go on, Google, you can ask, at least have an idea, and seek help at the right places. Possibly she saw a GP that maybe doesn't really understand that particular condition. So you might need just to talk to specialists. It was when she now got to talk to the gynecologist, and I'm like, okay. That's what I said, you need to have a high index of suspicion. So if you're a specialist in that field, when the person is talking to you, you already have an idea, okay, this could be this, and that's why he advised for a laparoscopy. Even with a basic ultrasound scan, with a good, possibly a three-dimensional ultrasound scan, will actually give us a good picture of all those endometriosis on the ovary, and we get possibly this endometriosis. So when they did the laparoscopy, they had a diagnosis, and most likely they will put on hormonal treatments, that will allow her to do basic functioning, because that will, those treatments, they are hormonal, they in a way stop, they told that it's that shedding of those endometrial cells. So like seeing your menses, that's what worsens it. So those hormones, they kind of cut off, like stop that menstruation. Do you understand? So that hormone will not allow them to menstruate, because once they keep menstruating, because I told you that she menstruated for about 21 days, and I told you that people that have shorter cycles, they have heavy flow, they are the ones that have this risk.
Susceptible, yes.
Do you understand? Yes. So the thing is, they will give her drugs, and say all those non-steroidal anti-inflammatory drugs won't be able to work on that anymore, because it's beyond, just prostaglandin stuff. So you want to go to hormonals, like the combined hormonal contraceptive, progestogens, it could be mouth, it could be injections, which will, you can take it maybe once in 3 months. So it will actually stop you from menstruating. So that will give you a pain-free period. There are also step up to other ones like the gonadotropin releasing hormone agonists.
Okay.
That one also, will mimic a kind of menopausal state, so that you just be dry. So and that is why, she told us she had a son, but I'm sure most likely she had an IVF.
Possibly.
So by the time she's ready to get pregnant, those medications will be stopped. Then she will now commence the treatment, and she will have a son. And the thing is, some people are also, because the period of pregnancy also can actually, because you're not also, a period of pregnancy, you're not menstruating, so that will also take care of the pain for that period. And over time, she gets better and better over time. But once she gets out of that menopausal, 50-year menopause stage, she gets much better. But for those that probably they've had their children, with their complete family size, when you remove those bulk, that's why the advice is hysterectomy, which is not like it's like a wrong option.
Okay.
But because she was young, that might not be the best option for her. For someone that's maybe around 40, she's delivered all she wants to deliver. She can actually remove her womb and her ovaries, take them out. That will remove her menstruation, and that sorts out, the bulks as much as possible, and that removes the pain considerably.
Wow.
Yeah.
Wow. I mean, I was going to, because a viewer sent in a question about the pregnancy and the pain, but you've already answered that, where, well, because menstruation doesn't happen during pregnancy, so it means that the pain would subside reasonably. And I mean, this is something that a lot of people don't even know about, and I'm glad that we're able to have this conversation. I'm sure that when next you come, we'll open it up even more to see different things when it has to do with endometriosis. But a lot of people out there now know, but they are stuck in the fact that they don't want to. So there's something about ignorance that is based. They know that, there is pain, but going to find out what it is scary for them. I would like that you advise people, like, to talk to them so that they're encouraged to go and find out what it is and actually, take that step in getting themselves treated.
All right. To teeming Nigerian population, ignorance is a killer. And it's good to, if you're educated enough, you cannot just, if you go online, just type pain. I'm sure some things will pop up. At least gives you an idea of what it could be. Because many people are not readers, you may not, just keep suffering in pain and all. And also seek help in the hands of specialists. Don't, because specialists, they are prone to a particular area, and they're able to have an idea of what is happening. Even if you don't exactly know, if you go to a good hospital, they'll be able to refer you, when you look at this case, they refer you to the appropriate specialist that you ought to actually go to. So seek help at a good hospital where they'll be able to invite the relevant specialist to you. Because sometimes, like, assuming the person comes with maybe fluid in her chest, like maybe coughing up blood and all, the initial thing is, probably is a chest, maybe it's a chest surgeon that we need to come and see, or a chest physician and things like that. But when the chest physician possibly comes and he asks some questions, this is not ours, it is possibly a gynecologist case, and they will not invite. I've seen a case like that before. Someone had this kind of fluid in the chest, and they drained it, but they now asked further questions, and she now realized that it's related to her menses. That's why I got called in and we were able to manage her with hormones, and she got fine, and she could live her life, and quality of life significantly improved. So we need to improve our health-seeking behavior, ask the right questions in the right place. And also it's good for the government as well, because when we have this universal health care, people are able to, because sometimes it's the money, like, I don't have money because I was at the fora, and I was talking about people, they don't have money to go for this. So if there's universal health coverage, like all these insurance cover, people are able to access health care and ask questions and be able to refer to the appropriate, specialists that will be able to attend to their needs. But people need to have a good health-seeking behavior. Don't just sit back. Science has so much advanced that there's almost a solution to everything. Look at COVID-19. It was a novel disease, and within a space of months, we had vaccines for it. So people are doing research every day. So talk to the right person. Use your phones, listen to programs like these where you get educated on health-related topics, and you'll be glad you did.
Talking about using your phones before we wrap up, I mean, there are times whereby I don't like Googling things because it scares me. There is this particular popular website where the moment you just type it in, you say, okay, I have a headache, they can just give you various symptoms, and then you get to, is this happening to me and all of that. That's one of the reasons why I'd just rather talk to a doctor. Like, most times talk to a specialist.
Yeah, well, I'm just saying phone is like, rather than just sit and just have an idea of what exactly is happening to you. At least that just gives you a basic idea. And next thing is for you to seek help with the right practitioner. Go to a good hospital. You can see a GP in the first time, because you may not even know where exactly the problem is. But I told you the problem is not specific. It can mimic anything. But fortunately, if you speak to a good doctor, you'll be able to invite the right specialist in that field to attend to what you need.
Thank you so much, Dr. Victor. This has been enlightening. We just finished the conversation on endometriosis, and I've learned so much. The number one thing that I've picked up from this conversation is have a good health-seeking behavior. Find out what is wrong with you. If you're going through excruciating pain, especially during your menstruation, there's a high possibility that something is wrong somewhere, and you need to talk to a doctor. I mean, of course, the first point of call is to see a general practitioner, but as time goes by, maybe it's time for you to see a specialist that can actually check you through and see that this is what is up for you, so you can get treatment. Please, it's so important, and this is one of the reasons why Tea or Coffee brings up these kinds of conversations, just to open up things like this. Thank you so much, sir, once again. This has been enlightening.
Thank you.